Well, hello, good morning, good evening, good afternoon to everyone around the world. We're really excited that you're here with us today. We are looking at a webinar on TB and HIV screening in the private sector. We have an excellent panel during a busy UNAIDS and AIDS and ICASA conference. Many people are interested in HIV and TB, and we thought it was a great opportunity to take this to talk about TB and HIV screening, and realize also that everyone is super busy in December, not just with the events that are happening, but also with, of course, the continuous COVID pandemic that is affecting a lot of people. So we want to do a shout out, especially to our colleagues in who are joining, who are in the middle of dealing with a lot of COVID cases at the moment. So appreciate this, and we thank everyone for showing your interest and support to tuberculosis, which is of course a secondary immediate impact from the COVID pandemic that we need to look at. So today's topic, we are looking at understanding more on how we can integrate screening services for people affected by HIV and TB. As everyone probably knows, HIV is a key driver of tuberculosis, and TB is the leading cause of death among people with HIV. So really important that we look at that, accounting for about a third of all HIV-related deaths. We have seen that scale-up activities, as WHO recommends in their guidelines, have saved 9 million lives. But last year in 2020, our data show that half of the people estimated to have HIV-associated TB did not reach TB care. So it really is an issue that needs some attention, and we know that within the community, people have asked for guidance. Early diagnosis and early treatment of HIV-associated TB is critical for survival. In this webinar today, we look at questions related to TB/HIV screening and testing in the private sector, and we hear from practitioners in the field on their work. So I'm really pleased with a very powerful panel today, and I'm excited that we have different perspectives that we can bring to today's table. As a general notice before we start and I introduce the people, I would like to just quickly say that we're live streaming on YouTube. There is a Q&A button that probably everyone is already familiar with in the bottom of the screen. Please post your questions. We're really looking forward to hearing from you. Share your experiences, ask questions, use the Q&A button to communicate with us and with the panel members at any time during this call. Our panel members will try to respond to you directly, and we will also have a guided panel discussion in the 90 minutes that we have today. So to start us off, I'm going to introduce the different speakers, and I would like to first introduce Zinc Twane. She is a TB survivor who is currently doing a master's degree in medical science at the University of KwaZulu-Natal in South Africa. She also is connected to the Connect TB project where she works as well, and she was a client in the mystery client in the research product that they did. So with that, she has a lot of experience, not just looking at how different private practitioners deal with tuberculosis patients, but she also has experience herself as a TB survivor. So we look forward to hearing her experiences and bringing her perspective to this table today. Then after she will start us off, I will hand the floor over to, why don't I just let Zincle open our meeting, and then I'll introduce everyone in between afterwards. So go ahead, Zincle. Can I ask you to maybe take the floor and put on your video? There you are.
Greetings, everyone. My name is Zinc Twane. I am a TB survivor and also a medical science student at the University of KwaZulu-Natal in South Africa. Thank you, Petra, for introducing me. I was diagnosed with TB when I was 16 years old, when I just recently moved to a new city just after finishing my matric. I suddenly became very ill. I was coughing. I lost weight. I didn't know what was going on until my neighbor who talked to my mother I believe that he had a little knowledge of TB regarding the symptoms that I had. So he advised my mother to tell me to go to the clinic so that they can check if I have TB. So I went to the clinic where the nurse asked me how long was I coughing for. I then told the nurse that it's been weeks now since I've been coughing and it's not going away, and I lost so much weight. So the nurse asked for sputum, early morning sputum the following day that I should bring to the clinic. That's and then I would come back after a few days to check for results. And I went back to the clinic. I was informed that I had TB. I didn't understand my diagnosis. I wasn't told any information on TB. I was only told you have TB and you need to come and collect medication weekly. During that time, we had to collect medication on a weekly basis. There was no information shared to me on how you can get TB, on how TB can be treated. I was just only told for you to get better, you need to come to the clinic weekly to collect medication, and you need to take that medication for full duration every day. I was so confused with the diagnosis as I was still young. I then went back to my mother, who encouraged me to continue taking this medication that I didn't even understand. It was so hard to continue taking medication after a few weeks of feeling better. I then continued taking medication until full duration with a lot of challenges that I faced, but my mother was on my side to support me throughout the journey. But I didn't get a lot of information on what was TB, on what is TB, how one can get TB. In my mind, when I was diagnosed, I was only thinking, what came in my mind was that I had HIV. I don't know why. I was still young, but I just associated TB with HIV. I just thought, oh my God, I'm gonna die. I have HIV. With less knowledge that I was given, I was confused. I continued. I think if I was not young, still listening to my mother, I really am not sure if I would have continued with medication, because I didn't have knowledge. I had side effects that were not a major side effect, just minor side effects, like changing of urine color. Those were the things that I wish someone had informed me that they would happen when I was taking medication, but no one was there. Only encouragement from my family that I should continue taking medication. I then was a patient actor on the study that was evaluating the quality of TB care in the private sector, where I was a patient actor in a case where I had TB before. I was also HIV positive. And during that time, we interacted with a lot of doctors, private providers, which a lot didn't inquire about my HIV status as a patient actor. What they wanted to know, or what they were interested in, was the fact that I had stopped taking medication, and it's not the first time that I had TB. So doctors reacted differently. Other doctors would jump as soon as they hear that I had TB before and I didn't complete my treatment. Others would jump, would not ask me about my HIV status, but would jump at telling me that you need to have a test. So that was just confusing, because you don't even want to know my HIV status, and you don't explain how HIV and TB are related, but you want me to test for HIV. If only information was shared on why they would at least ask for my status. To those who asked for my status, they would explain why you need to have an HIV test. Maybe I would have had clarity on why they want to have an HIV test. So that was my experience, and a lot of providers did not inquire about my HIV status. Those who inquired didn't have a lot of information to share on how TB is related with HIV. They were just only interested in the fact that I didn't complete my treatment. They didn't refer me to the clinic. Others would refer me to the clinic urgently, and others would write a note to the public clinic so that I can just get checked up for TB, since I had TB before and now I'm presenting with symptoms. So there was a variety in the response of private providers. Thank you.
Thank you so much for sharing your story and your experiences. And I think it's really important to hear how the different providers actually responded to you and reacted to you. And I think that voice is giving us a lot of information that we need to really incorporate in our work when we think about tuberculosis services, but also about HIV service. Zinc Twane, thank you for your brave story and for being connected to the work that you do right now, and your good luck with your master's degrees. I can see that you have a powerful voice, so we look forward to hearing more from you in this work. And please join on our panel, because I think your voice is going to be really important in the discussion. So for everyone in the audience, please feel free to post questions directly to Zinc Twane as well. I'm sorry for not pronouncing your name correctly. I'm not fluent in the South African language, but it's a beautiful name. Now, I would like to introduce the rest of the panel, and thank you for setting the scene in the right way, Zinc Twane. In the rest of our panel, we have a strong representation of various countries, and I will introduce each of the panel members before we go into the presentation. So with us today is Dr. Refilwe Machi. She's the CEO at Equity Innovations, and she is a recognized authority on TB. She's an international leader in implementing TB projects globally, as well as designing and implementing programs for TB-HIV co-infection. She's an international public health professional, bringing 13 years of experience in TB and HIV program management. And she will talk to us about her programs in equity in South Africa. Then with us is Dr. Nyawira Gitahi. She's the executive director of Goldstar Kenya. She's a passionate and pragmatic senior global health researcher, a technical advisor, and a program manager with 15 years of experience in Africa. And she will share her work that she's doing with Goldstar in Kenya, looking at TB and HIV programs in the country. Then a third panel member that I'm happy to introduce is Dr. Adil Tahir. He's a medical doctor with a post-graduation in public health from the University of Wollongong in Australia. He has more than 12 years of experience in the public health sector, including 7 years of experience in TB control, both in the public and private sector. He's currently working in Mercy Corps, Pakistan, as a senior technical advisor for health. And he has a portfolio where he manages the Global Fund project, and he's also in charge of the Global Fund, the COVID-19 response. Then we have Cheryl Johnson, who is a technical officer at HIV testing services in the HIV department at the World Health Organization. And she's also a PhD candidate at the London School of Hygiene and Tropical Medicine. She will be sharing her experiences and the important voice of the WHO guidance from the HIV side. And I'm really pleased that we have Annabelle Badley, who is at WHO in the Global Tuberculosis Program, where she is technical officer in the TB, HIV, and Community Engagement Department, and she will bring her perspective from the TB guidance. So I'm really happy that both of you can join us in our panel to reflect with some comments on the presentations from the countries. And then leading our panel discussion is Dr. Jody Baffa. She's a research fellow at the Center for Rural Health at the University of KwaZulu-Natal in Durban, and at the same time also at the Stellenbosch University in Cape Town. She has expertise in community-based research and epidemiology with a focus on TB and TB-HIV. And she's running a project, TB Connect, currently, where they also did the mystery research client information. So she will be asking some interesting questions to our panel and include all the questions that you have from the audience. So with that, now that you know what our program is, I would like to ask Dr. Refilwe Machi, can you please take the floor from me and present some of your lessons from South Africa, please.
Good morning, good afternoon, and everyone. Thank you, Petra, for that introduction, and also maybe firstly to thank Zinhle for sharing that story, because it's not only you, that's what we hear every day about how patients are managed with tuberculosis in the different settings. But I'm happy to hear that you are well and doing well, and keep up the good work. So today I'm really going to talk a little bit about one of our projects under Acute Innovation that has now been completed. This was a project funded under TB Reach. Next slide, please. Under the Stop TB Partnership, and funding was received under Wave 6 and Wave 6 Scale-Up. So the purpose of the project was to focus on public-private partnerships in one of the districts in the Eastern Cape province of South Africa, Nelson Mandela Bay Metro. And through this project, we had appointed private GPs on a contractual basis, focal nurses, and full-time community healthcare workers who were really the liaison with the community. And one of the things we should also highlight was that all the GPs that had been contracted under this project had free access to testing in public laboratories. Next, please. So just a snapshot for those who might not be familiar also with the work of the TB Reach. Before implementation, we had to identify an implementation area and also an evaluation, a control population. So our implementation area was sub-district C, and sub-district A was the control population. So this district is divided into 3 sub-districts, and we chose sub-district A as a control because of more of the populations were the same between the 2 sub-districts, and they were more or less reporting the same numbers of tuberculosis in those 2 sub-districts. Next, please. So what was the aim of the project? We had to work through the district office to identify private practitioners within sub-district C who were interested firstly to implement this project. And each GP was linked to 2 full-time community healthcare workers. The intention was that the community healthcare workers would go to the household levels of newly diagnosed patients, screen all the household members, and where possible, collect specimens for those who might already have symptoms or show any signs of tuberculosis. The specimens would then be referred to the public health sector. And in those circumstances where a client tests positive, the GP would contact the patient, not the community healthcare worker, and ask him or her to come to the GP rooms. And the GP rooms were already divided according to the areas to ensure proximity to those household services. Can we move to the next slide? We'll come back to this one. So one of the lessons, again, which we'll be talking about as part of the work that we were doing here, the community healthcare workers also used mobile phones to conduct the screening at household levels and already do mapping. So each and every household visited, we would be able to know where the house is located, how many people live in that household, and what were the results. And this is one of the good things that really came out of it, that with the data that was collected within a very short space of time, we could already identify the hotspots within that district. Can we go back to the previous slide? So really here we are also showing some of the data that were collected, people who were screened at household level, linkage to an index case, And also with this platform, we're able to identify patients that were being supported whilst taking treatment. And another good thing, the same platform is now being used to screen household members for COVID and other work that we are doing in the district related to pediatric TB. Next, please. Next. Thank you. So the key activities, I'll just focus that on those that are really, again, relevant for what we are discussing today, that from the onset, we engaged with the district and the province to ensure that we get the buy-in. And once that had been endorsed, we identified all the GPs that would be involved in this project. Just to mention, in that sub-district C, I think there are more than 20 GP rooms. However, we contracted 10 of them, where each one of them signed a service level agreement, or we had a memorandum of understanding. We also had to conduct just basic training on TB issues around the new diagnostic tests, the type of treatment being provided. And in those trainings, both the public and the private sector participated. Just in those trainings, a lot of lessons were already learned on how to improve the management of clients. We also had different monitoring and evaluation tools that were introduced in the GP rooms, including the screening tools, the registers, to ensure that the district can monitor and see what is happening. And the linkage to care for both drug-sensitive and drug-resistant TB, all clients that were identified, it is our duty to make sure that they get into treatment. Adherence support for those clients that needed it. And also just to mention, all patients that wanted to get their treatment from the GP rooms collected it from the GP rooms, not from the public health sector. And all children under the age of 5 years were referred for TB preventive therapy. Next. Thank you. So just in a nutshell, to share the results at the end of the implementation of this project, we were able to screen just less than 200,000 clients, with 10% of them being presumptive TB patients. We tested over 18,000 of those that were presumptive TB and found 1,444 with actually laboratory confirmed TB, which was a positivity rate of around 8%. And for all forms are just over 1,643. Also, the good thing, 96% of those that were found with tuberculosis were initiated on treatment. They started on treatment. At the end of this project, we successfully treated 819 of those that had tested positive, which was a treatment success of over 90%. With, again, this is the work that was done with the district. And on the other side is again the assessment from TB Reach, which clearly showed that the evaluation area, despite now COVID coming in, the project was able to increase case finding. And yet in the control population where now facilities were closed, that was a problem. The good thing also, all patients who were already on treatment during the strict lockdowns, the drugs for those clients were delivered to their homes. They did not have to come to any clinic to come and collect the drugs. Thank you. Next. So what are some of the key lessons which might be relevant today? I think the first thing is, again, the willingness of all providers to do much better for TB patients. It's a cumbersome job, and the good thing about the private GPs that signed, one of the things they brought to us is that on a daily basis, they see people who are sick, but because they do not have access, they just refer these clients to the public sector. And for the first time, they are able to literally diagnose them and initiate treatment in their rooms and support them. The provision of those commodities, free gene expect testing, TB drugs, And at the end now, the provision of HIV test kits within the GP rooms really addressed a lot of our issues. And the last one is addressing the patient needs. Our facilities work in very defined manner. Patients would ask, can I collect my drugs over the weekend? We had that flexibility. Or can I come after hours after work? There was flexibility for that. So these were some of the lessons learned. Next, please. So I think moving forward, when we talk of public-private partnerships, this is again a summary that we need to look at these partnerships at the different levels. The most important level is at community level, where we have either the private GPs, we have different NGOs, we have workplace programs who could be engaged in supporting either diagnosis or treatment of clients. At district level, we have public and private hospitals that can also work harmoniously to ensure that clients have access to testing. The national level, especially for South Africa, there are still issues around the gene expert, which is supposed to be the gold standard for diagnosing TB, with the exception of culture, of course. And yet the costs of gene expert in the private sector, they also contribute to the GPs not requesting that test. It's more than 10 years we have gene expert, and yet the prices still remain high, especially for the clients that we would like to serve. The turnaround time of results is an important one that we need to look at. The example of what Zintle said, she went to a hospital sick, and yet all she was given was a sputum bottle, told to go home and come back. People who are sick need treatment or to know what is the problem, not a sputum bottle. So it is important that as we talk of new diagnostics, we would get to a point where a person would be able to get the results there and there, be supported and start treatment. Next, please. I think my time is almost. So this is just, and again, what are some of the key components of a successful PPM intervention? We need the political leadership. We have heard of TB being declared TB an emergency for many, many years, and yet this has not translated into action. Acknowledgement that TB and HIV is still a major problem still remains in many countries, and we need to see this through better investments. Patient-centered care, I think I cannot re-emphasize that all of this we're doing to improve patient services. And I think today discussing public-private partnerships, it's time to address the cost of gene experts in the private sector. It also contributes to the private sector not requesting the test or the patients not being able to be tested. The tests are, the prices really are not acceptable. On the other side, really is just again a picture of some of our GPs that we've worked with. And these again are the dedicated people who would be working during the day, and yet they would make time either in the evenings or over the weekend to attend the sessions with us or the public sector to give feedback. And really, that's what was one of the success of these projects, the dedication of the GPs. Next. So really, in conclusion, maybe to our team today, I think we all remember the World TB Day theme, where we talked that the time is here. And I hope again, through this discussion today on TBPPM, it's time that we take these discussions forward and ensure that we just do not talk words and have some actionable items to recognize that TB cannot be managed by the public sector alone. We need to engage all. Thank you.
Thank you so much, Refilary. That was an excellent presentation. Thank you for sharing your progress with the Equity Project and the many interesting innovations that you're bringing to the fore with the AI and the mapping work is really good to see. And your overall picture, how you fit it in the health system in South Africa, is a very valuable lesson. And I really appreciate you sharing this and setting the scene. And we will hear more during the panel discussion. Thank you so much. I would like to now ask Nyawira Gitahi would you like to share your presentation and highlight some of the experiences from Kenya on how you work on TB and HIV programs? And we would love to hear from you. I see in the audience that there is a hand raised. Please put your questions in the chat. At the panel discussion, we might have some space to ask attendees to actually come in and ask a question, but in this stage, we would like to do the presentation. So if you have a specific question for Dr. Refiloway, please put it in the chat, thank you, or in the Q&A. Go ahead, Niawira, thank you.
So, good afternoon, good morning, everybody. Thank you, Petra, for this opportunity, and to the presenter who went ahead of me, excellent presentation. And to our TB survivor, I totally loved your braveness and articulate presentation. And I agree with you. Some of the challenges that you mentioned are actually some of the challenges we see every day. So as I mentioned, my name is Dr. Nyawira Gitahi. I am the Technical Director for Goldstar Kenya. And today I'll be sharing our experience on the HIV-TB screening private sector experience in Kenya. So Kenya is within the 30 topmost country in terms of the TB burden. And therefore, the TB is a major public issue for us. If you're able to see my slides, kindly let me know.
We can see, please go ahead.
All right, excellent. So Goldstar Kenya is a local indigenous non-governmental organization. It was established in 2010, and its focus is ensuring that there's integration, sustainability and locally driven evidence-based solution, primarily in the area of HIV and TB, both in the public sector and the private sector. Its roots and the name of Goldstar Kenya come from the Goldstar Network, which is a social franchise that includes private sector health-based providers. Within these providers are laboratory networks of different laboratories in the private sector, diagnostic centers that provide chest X-ray, CT scan services, healthcare providers, private practitioners, as well as those who have in facilities and larger hospitals within the private sector. And this is actually the only franchise in the country that implements a full spectrum of HIV services at a large scale. Now, the private sector TB framework in Kenya is embedded within the National Strategic Plan for our National TB Program, which runs the year 2019 to 2023. So within this strategic plan, there's a recognition of the private sector contribution. And the National TB, Leprosy, Lung and Diseases Program has also developed a public-private mix, a little bit like what we just saw with the previous speaker. Now, within this private public mix, there's a recognition that we do need to collaborate with private sector, not only to ensure that basic diagnostic services are available through the private sector, but linked to the public sector. Because one thing that we have realized is that there is a reason why some individuals will choose to go to private sector facilities, regardless of these services being absolutely free within the public sector. And so to ensure that we are able to still continue to provide the services, this was absolutely necessary. I just want to provide a brief snapshot of some of the counties that we work in. So Kenya's administrative units are called counties, and just picking from some select counties for 2019, we haven't talked about 2020 data because it was an interesting year with COVID. But I think what I want to just highlight here is that the private sector contribution is upcoming in some of the counties, almost 30%, such as a county such as Mombasa County. However, in places such as Makueni, and you would see that is merely contributing to around 2.1 of the private sector contribution, either to diagnostic, bacterially confirmed, either clinically, TB in children, MDR, name it. So this is about the private sector coverage. And I think what I would like to highlight is that the screening rates usually within private sector, public sector is usually at around 95%. And we'll see what that looks like in the private sector. And then usually for the private sector, we have an average of around 700 TB cases identified annually. And at the same time, within the Goldstar franchise, we're talking about having a bit over 12,674 clients on ART. This is really a drop in the ocean for a country that has almost 4 to 5 million Kenyans on ART. So our mandates and what we hope to do as a private sector provider for TB within this mandate is to increase the number and coverage of private sector providers who are actively collaborating with the national program. And this means that we continuously enroll private sector facilities and labs and pharmacies within the framework. And almost like the previous speaker had said, a little bit like that, we have memorandums of understanding where we have certain areas of ensuring that we have an agreement with the facilities to provide capacity building and quality assurance towards TB and HIV management. And they in turn have certain advantages and benefits, which include cluster model, commodity management, linkage to even government-led laboratory services and commodities, and you'll see that shortly in the coming slides. And to strengthen, again, the quality of care in TB is also very essential. So we have the mandate to go in and train, provide updated guidelines within the HIV private sector. A lot of the quality of care in terms of guidelines and capacity trainings that occur routinely within the public sector are not as common in the private sector. So there's often a knowledge gap within the private sector practitioners, and this is what we come and fill in. We also hope to increase the number and proportion of TB cases notified. Now, TB being a public health issue, notification is actually mandatory, but many times this does not actually happen. And this translates in inaccurate data, especially in counties where the private sector contribution is extremely high. To increase the number of individuals tested for HIV among TB cases, of course, is another mandate, taking into account there are not other many private franchises that actually have specialized and focused on HIV testing. And just to bring up context into the private sector role, a recent patient pathway survey currently reported that 42% of the individuals with TB symptoms first sought care in the private sector, making the private sector very important. And it's the same with the HIV testing as well. We see almost 50 to 60% of the individuals who eventually end up in the public sector for HIV treatment and management, again, showing up first in the private sector. So what are the gaps that we're seeing and we've seen? So the biggest thing is around screening. It doesn't come intuitively to private sector clinicians. There's a low index of suspicion, especially with pediatric patients. COVID also brought its own nuances where, of course, there was a shift in priorities, and then the capacity of healthcare providers, as I've noted. Diagnosis, access to gene experts is a challenge. The prices are just as high in Kenya for completely private-led gene expert services, and therefore this is a gap that has to be filled in. And then access to radiological services is also an issue. It would be expected that a chest X-ray is a basic service. However, even within the private sector, there are different tiers. So there are tiers that are, high insurance coverage, and then there's a very basic community clinic that may not have the radiological services such as, X-rays. HIV testing of TB cases and contacts, again, is a difficult conversation that many private practitioners do not have with their clients. And I liked what the TB survivor said, that nobody explains the rationale of the need to have HIV testing to an individual who's been diagnosed with TB. Perhaps it's from an area of capacity. Many times it's the nuances of private sector healthcare worker relationships. And then lastly, even those who are tested and are found to have HIV may not access ART initiation or may be lost. Primarily, back to my point, there's a reason why many people come in to seek certain services in the private sector. Many times there's a feeling of sometimes perceived better quality of care. Sometimes it's because there's perceived confidentiality and anonymity that may not be there in the public sector. And when the TB management is done or has to be started within, continuing towards ART management, if this client has to be referred for whatever reason to another facility, we often will lose them. So within our program, this is just to point out some of the critical data gaps that we're seeing. This is just data from, I think, a half-year period where we had around 730 new TB cases, with 84% of them tested for HIV. Ideally, we should be having universal testing. And then with looking through a yield of around 16.66% of those who were tested for HIV, even if it was a little suboptimal. And then moving on to ART initiation, we haven't been able to link everybody, each and every one of these individuals, into care. And back to my point about the need to sometimes transfer or refer these clients. This is because many private sector providers do not offer the entire spectrum. Some would be testing, but not offer ART in completion. So some of the strategies and some of the learnings we have as I come to a close that we've learned as Goldstar Kenya in this private sector space is capacity, building our private sector healthcare workers. We're talking about the new guidelines. Are we moving to LAM? Is GeneXpert the main, source of, does it have a higher yield? And really going into the data and explaining to them so that they're able to change their daily practices. Most healthcare workers want to do the right thing. Most healthcare workers only need to be equipped to be able to have an increased level of suspicion or index of suspicion to start screening and do it. The use of online platforms, especially in the context of cost effectiveness, has been useful. I mean, this now is a sustainable model that works on its own, having established the memorandum of understanding with the facilities, ensuring that we're using the membership subscription or partnership with the pharmaceutical space or diagnostics to ensure that we continue to have the within experts among the experts. There's a hub and spoke model that we're also using with regards to capacity to ensuring we have commodities. So we have a larger facility being the hub and other smaller facilities providing, taking in their samples for GeneXpert and commodities. So there are many strengths that we've mentioned within the presentation, but thank you very much. And thank you for your audience. We'll be open to questions later on. Thank you very much.
Thank you so much for this excellent presentation. It really gives us an insight on the various steps and where the TB and the HIV services in Kenya are having struggles and gaps. And I really appreciate your honest and open presentation. Thank you so much, Nyawira. That was really good to see. I would like to now ask Adil Tahir. He is going to be presenting and we will be sharing the slides for him. So if we can pop up the slides, that's right. Adil, do you want to take over from me and share some of your experiences from Pakistan?
Thank you, Petra. Yeah, sure. I hope I'm loud and clear.
You're loud and clear. Yes, go ahead.
Okay. So thank you again, Petra, for a wonderful introduction. Today, the purpose of our presentation is TB and HIV screening in private healthcare sector, and I'll talk about mostly our experience in Pakistan. We in Pakistan has a healthcare system that is divided into two sectors, that is public and private sector, as in most of the countries. And the TB program is very well established in both the sectors. We have almost 1,400 BMUs, the basic management units in the country in the public sector, and almost 20,000 doctors on board in the private sector for TB care. Mercy Corps Pakistan is the sole PR for private sector for TB care in Pakistan. So based on that, my presentation, I will discuss the statistics of HIV in Pakistan, the statistics of TB in Pakistan, and the challenges for TB HIV screening, and then I'll share some way forward how to address those challenges. So firstly, we'll talk about the statistics of HIV in Pakistan. As you can see in my slide, if the estimate says that there are about 200,000 people, adults and children, living with HIV in Pakistan. Considering a population of about 220 millions, the number seems quite small. But the rate at which they are increasing, it's alarmingly high. Perhaps we are increasing the rates at the second most, in whole of South Asia. If you talk about the incidence of HIV per 100,000 per 1,000 population, it's about 0.20. When we talk about a little bit of detail about the HIV population in Pakistan, we'll see that most of these cases are in the key populations. About 53% of these cases are in the key populations. And the key populations include MSM, men who have sex with men, and they constitute about 25% of the cases. The people who use injectable drugs, they constitute about 24% of the cases. Then comes the female sex workers, which constitute about 2% of the cases. Transgenders, again 2%, while the 47% of the cases, they belong to non-key populations. So we can see that the epidemic in Pakistan of HIV is a concentrated epidemic, particularly in key population. But now we have issues. The main important issue is that we have low prevention and testing coverage in all of the country. And only, you can say, 14% of the people who are living with HIV in Pakistan, they know their HIV status. So unless until we know the extent of the problem, how can we address it? Again, those who know their HIV status, their treatment coverage is quite low. Only 12.5% of the estimated PLHIV, they are covered under the treatment, and for key population it's just 9%. Those who started treatment under the program, they have high attrition rates. Only 26% of the patients who retained at the end of 12 months of cohort, and this number go down to 11% at the end of 24-month cohort. So we have issues. Although the numbers are small, but the issues is that we have very little reach to the population. Then the treatment coverage is low, and then there are high attrition rates. Next slide, please. Okay, now I talk about a bit of TB statistics in Pakistan. As I mentioned, that Pakistan is a country of about more than 200 million people. The incidence of total TB incident estimated is 573,000 in the country, with the incidence rate of 259 per 100,000 population. If you talk about HIV positive TB incidents, it's 14,000. When we compare it with the notifications, we see that in 2020, we were able to notify 273,000 people, 273,000 TB patients, both new and relapse, which is about 16% reduction from the year 2019. And this is mainly due to the COVID-19 pandemic. So we can see that there is a huge impact of COVID-19 pandemic in the country, and our case numbers gone down for TB. If we talk about TB and HIV, then the TB patients with non-HIV status who are HIV positive is just 0.07%, which is too low. HIV positive TB patients on ART is 65%. So out of 0.7% who know their HIV status, only 65% of them are actually receiving antiretroviral therapy. If you talk about treatment success rate in the country, overall, it's very good for the TB patients, it's 93%. But we talk about TB HIV patient, then it's just 81%. So these are a picture of the statistics of TB in Pakistan. And when we see the picture, we'll see that the situation becomes graver when we see in the context of TB and HIV. For screening, if we just talk about screening of children in Pakistan, and now there are many issues. The screening in Pakistan is very much affected because of the lack of funding. I'll talk about the issues in the next slide, but if I give the statistic that the number of children who are contacts of biologically positive TB patients and who are on TPT is just 5%. So there are a lot of things that need to be done, seeing the context of TB burden and the HIV in Pakistan. If I talk about the challenges, the first challenge I put here is the stigma. The stigma for TB is because it's linked to malnutrition, it's very old disease, it's linked to poverty, low social class, and there is a fear of transmission from a person with, who is infected with TB to other person. So, this stigma is the main barrier in reaching to the patients for TB and then screen them for TB. Similarly, the stigma is attached with HIV screening, like all over the world. It's people think that HIV is transmitted through sexual intercourse, so they don't know about other modalities. Like for example, in Pakistan, HIV, the main source of transmission is the use of injections by healthcare workers, and recent outbreak in Larkana in 2019 is because of unsafe injection practices. But the people do not really consider that, and they think that it's mainly through the sexual intercourse, so they hide their disease. So the stigma is the main key challenge that is hindering our fight against TB and HIV. Then there are funding constraints. The funding constraints are huge. Like, for example, if we talk about the tuberculosis, only 42% of the whole funding requirements are being met, and that too are by donors, mostly by the Global Fund. Only 2.4% funding are met by the domestic resources. So we need a lot of funding, to meet the challenge of screening TB and HIV. Then there is lack of advocacy. Most of the healthcare providers, they are not very much aware of the this TB and HIV synergism. Mostly in Pakistan, the healthcare providers, they run the private clinics. These are small GP clinics, which caters about 100 patients a day on average. There are no facility of patient triage and very congested sitting places. So there is a very little opportunity to get the testing or screening of TB and HIV in those clinics. So what we have to do is to refer those patients to nearby laboratories. And while doing so, we face a lot of pre-treatment loss to follow-up. Those who reach to the laboratories, they undergo testing, and then they have to come back to the doctors and to start their treatment. So for TB, it's working a bit fine, but for HIV, this is the main challenge. Because whenever a doctor prescribes a patient to go for HIV screening, the patient, you just change the doctor or go to some other healer, you can say some other healthcare worker, just to avoid this HIV testing. Then there is insufficient infrastructure. Mostly, as you know, that for the screening of TB, we need X-ray facilities. But these X-ray facilities are very limited, particularly in the private sector. And the cost will be borne by the patients. And it's almost about, if you talk about in Pakistani rupees, it's about 800 Pakistani rupees per X-ray, which is not affordable for most of the people. So this is the main challenge. If once we diagnose a patient with bacteriologically positive TB, our staff reach to them and they motivate them to get screened at the nearby health facilities. But then there is issue of travel cost, and then the cost of the private healthcare providers for screening, and then the screening for the cost for X-rays. That is the main issue. So this is the area where we are struggling, and the people, the context of the TB patients, they are not undergoing screening for TB. Then there is non-availability of HIV self-testing kits. Although, as I mentioned, this epidemic is limited to the key populations, and the HIV program is advocating about HIV self-testing, but still it's almost non-available for the key populations. And so because of this, we are unable to screen people at the district level or at the field level. Then there are non-availability of operational guidelines for HIV testing of TB patients, particularly in private sector. This is an important point I like to highlight here. As I mentioned, that we do not have a national level operational guideline that clearly educate that how a TB patient who is diagnosed of tuberculosis in the private sector will undergo HIV testing, from where the kits will be made available, who will do the testing, how the patient consent will be taken, and then how the patient will be referred to the ART center for further confirmation of the diagnosis. So this is an issue. Without that, we are unable to screen both TB and HIV. Then there is non-availability of preventive TB medicine. This is also an issue. If we are able to screen some of the TB patients or the contacts of TB patients, then we do not have the preventive medicine available. Even for children, these are very less in amount, and for adults, we are still, in the process of making a guideline where we will standardize the treatment regimen for the preventive TB medicines. In the past, actually, this preventive TB medicine part is not very much focused, but now in 2021 we are focusing on it, but still we have a lot to do. The latest challenge is COVID-19 pandemic. As I mentioned, that the case numbers have gone down due to the COVID-19 pandemic in the country. And because of the same sign and symptoms of TB and COVID-19 pandemic, the people are reluctant to undergo testing for TB, and even the practitioners, they are reluctant. Anyone with symptoms of respiratory tract infection, they are being referred to other centers where there is COVID-19 facilities. So in that scenario, we are missing the TB cases. Next slide, please. Now I'll talk about some of the proposed actions that we can do to address this challenge. The first and most important thing is to strengthen the existing coordination between National AIDS Control Program and the National TB Control Program. Although the two programs, they are working for the last almost 2 decades, and they are being funded by the Global Fund, still there lack of coordination, in true sense. There is lack of sharing of the data, and based on that, we cannot even ascertain that which areas to be focused more, which are the hotspots for TB and for the HIV patients, and how to screen for both the diseases. Then we have to ensure the surveillance of HIV infection among TB patients. Now, this is very much important. As I mentioned, that we are facing this challenge, particularly in the private sector, because of the non-availability of the kits, because the doctors are reluctant to do the test in their private clinics, because the patients are reluctant, and we will face difficulty in getting their consent. And then because of lack of the referral facilities, only 40 ART centers are working in a huge country. So where to refer the patient for confirmation of a diagnosis? These are the issues, and we need to work on those to get proper surveillance of HIV infection among TB patients. And similarly, the testing of TB among people living with HIV is also very much troublesome. As I mentioned, that we have only 40 ART centers working in the country. So there are very little general practitioners or private health facilities that are providing care for HIV. Mostly in private sector, the services of HIV are almost non-existent. So the people have to go to the public sector for HIV testing and further treatment. Although it is mandatory as per the guidelines that all the patients who are diagnosed with HIV should undergo TB testing. But again, the staff at those centers, they are not very much trained in how to diagnose the TB. They collect the sputum, and as per the guidelines, the sputum of those patients should be tested or gene expert, but still there is lack of coordination. And once the patients are diagnosed with the TB-HIV co-infection, now there is a lack of coordination whether the patients will be treated at the HIV center or they have to go to the PPM clinic where they'll get their treatment for TB. So these are the things that need to be looked into. Then the training of staff at sentinel sites and TB laboratories. Again, as I mentioned, that the staff at the TB laboratories, they know how to diagnose tuberculosis, but they do not have any idea how to diagnose HIV. And similarly, the staff at the sentinel sites, they are well aware of doing the dipstick test for HIV, but they do not have any idea how to collect sputum for TB. So we need to train those staff at both the diagnostic facilities, and this will help a lot. Then undertaking joint TB-HIV planning to integrate TB and HIV services. In Pakistan, TB and HIV programs are, I say that these are vertical programs, and they do not usually coordinate with each other on frequent basis. But we need to develop a strong coordination between TB and HIV services. Now that under the Global Fund program, UNDP is the principal recipient of HIV grant, so we look forward for joint TB-HIV planning to integrate TB-HIV services. Then there should be prompt treatment available for TB-HIV co-infection. Mostly, as I mentioned, that the patient, they are diagnosed with HIV, but they are unable to start their treatment because of certain many reasons. So we need to look into those reasons, and we need to ensure that their treatment should be available. And the treatment of HIV infection should be available in the private sector. That's the most important thing that we need to do. Then there is availability of preventive therapy. This is another important action that we need to take, and we need to decide the regimen, whether which therapy we need to choose it for adults and for the children, and made available for all the private healthcare providers as well in public sector. Then there is much needed well-organized advocacy campaign at national levels. This is very much needed, particularly because if I talk about the awareness of the common man in the country, they perceive these both diseases as the stigma, and they hide their disease. So a well-organized campaign that is being led by the government, that is very much needed. And we see that during the COVID-19 pandemic, a well-organized campaign by the government did very well, and the people who are reluctant initially to get tested for COVID-19 and to get undergo vaccination, they change their mind, and we see the response. So a well-organized campaign on the same lines would very much help in getting TB/HIV screening, and it should be on the agenda of the country. So that's all from my side. I'll welcome the questions. Thank you very much.
Thank you. Thank you so much, Adil. Those are some really important points that you're bringing up from actually the experience immediately within Pakistan, and really good to hear your reflections and your points on what's working and what's not working. Now, I would like to ask all panel members to turn on their camera. So we're closely going to go to a panel discussion. But before we do that, I would like to ask Cheryl Johnson and Annabelle Badley to give a short comment on the presentations that you've seen from the countries, and maybe from your perspective from WHO and the work that you do with guiding countries on policies. Can you give maybe a 1 or 2 minute short reflection on some of the key messages that you would like to highlight? Cheryl, maybe you want to start?
Excellent, happy to. And just to say, what an excellent summary and excellent speaker so far, just learning so much. Some kind of reflections I might have, coming from the HIV testing perspective, is it does seem like we recognize the challenges that countries and the private sector might face with offering testing, because generally most testing programs are not really as present in the private sector in the HIV context as they are in the TB world. And I think that is the challenge we have to think about how to overcome. It definitely, I think, is this challenge in some contexts. I'm thinking just about our speaker from Pakistan, when you might have higher incidence of TB than HIV nationally, and figuring out this trade-off of how to add HIV testing or into either testing or screening among those that are presumptive TB or active TB cases. And so I think that's an area I see maybe for further discussion in this nice webinar today, but also for the future. I think that something that also has come up is the opportunities or challenges with introducing or integrating in HIV self-testing. HIV self-testing is really a recommended approach at WHO, and we see a lot of opportunities here, I think, just from all that the speakers have shared, that when there are challenges in the private sector and among private providers, that there could really be an opportunity here to explore and do more, especially given the gap when you are, following up and seeing some of the cascades and information coming out of Kenya. And that presentation, I think, really highlighted to me, given that context where self-test kits are widely available in the private sector, maybe there is a possibility for TB contacts and others to access HIV self-testing, or for private providers to be able to include that in their services. Similarly, while it hasn't been touched on too much, one of the other important venues for implementation of self-testing that could also be really meaningful for integration of TB and HIV activities and testing would be self-testing within the workplace, and really building up those workplace programs, workplace wellness, and programs that I think TB and HIV have kind of shared populations that really would benefit. So sometimes it's mining companies, just as an example. There definitely, I think, is a lot of opportunity, whether it be self-testing or integrated service delivery, that workplace programs offer an important entry point that are kind of quasi-private sector, but also can engage with the public sector as well. So something, I think, for more discussion about how we really close this gap. But I really do appreciate all the comments and presentations highlighting the kind of priority that we really need to move ahead on making sure HIV testing is more accessible to those that are receiving TB services in the private sector, that we are missing strategic opportunities. We do need to find strategies and solutions moving forward, whether that be integration on the ART side that came up, but also making sure that we are getting the testing offered from the onset of services delivery. But just want to thank everybody, and maybe hand back to you, Petra.
Yes, thank you, Cheryl. These are really important points, and you're actually nicely setting the scene for the discussion and for Jody to take over. But before we go there, and before I hand over to Jody so that others can respond, because you bring up so many good points, I'd really like to give Annabelle an opportunity from a WHO tuberculosis perspective, some of the comments or immediate reactions that you have to the presentations. And then afterwards, I'll hand over to Jody to take the discussion forward. So Annabelle, the floor is yours.
Well, thanks very much, and very much for including us in this very important session. And starting off with Zinle's amazing this talk and sort of insight into what it is to be at the end as an end user in what seems to be chaos, really. And I think it's quite interesting. That I think somebody mentioned that, you know, the health can be divided into two, into private and public, but actually in reality it's more, because we have the TB and the HIV programs siloed. I mean, this very much, the siloing depends very much from the regions and the countries, but I think probably in places like Pakistan, it might be a little bit more siloed due to the nature of the HIV epidemic. So, I mean, all the points that you brought out, Adil, about the importance of collaboration between the TB and the HIV programs. And I think that is key in sort of working out and engaging with the private providers. And I think, you know, and also the public providers, you know, for instance, prisons and those that are sort of outside the health sector system. So I suppose on the HIV side, I suppose one needs to sort of look, perhaps, you know, sort of work, the TB and the HIV programs need to work together to identify HIV private providers that might be interested in taking on TB screening. You know, sort of the question is what is the, I mean, somebody, I think it was Adil who mentioned, you know, the lack of private providers in the HIV side potentially. And I don't think this is particularly you know, I think this is quite common in many countries. You know, the TB private providers seem to be much more. And so the key is how we work out the HIV testing without the TB providers being worried about losing their clients later down the cascade in terms of treatment. And I suppose the big thing on that is capacity building, right? And working the TB and the HIV program, working together on that, because it's in the interests of the HIV program to make sure that TB and HIV treatment is delivered together so that they don't lose their population. So on that side, there are a number of other screening tests that are available from the TB side for people living with HIV, like CRP. There's also chest X-ray. And I think there are certainly in the private sector, there are countries that have sort of, you know, the public-private, there's a kind of contract that's going on. And I think, you know, countries may be going towards screening people living with HIV once a year with chest X-ray in addition to the usual symptom screen, which may be an opportunity to engage private providers more. And CRP also, it's not just a simple symptom screen, it's a biomedical test so that, you know, it's much clearer. Delivery of the symptom screen is a tricky one because of the quality. And then on the other side, I suppose, you know, it's the HIV testing amongst the TB patients, which I think, you know, as I say, I think Cheryl's really answered all of those questions. But, you know, I think it's capacity building, and it's coordination between the TB and the HIV program to engage TB and HIV private providers. I guess that's what I sort of take home from this. But thanks very much. And looking forward very much to hearing what the others say. Over.
Well, thanks so much for everyone's participation. I mean, I think there's a lot of there are a lot of questions floating around and a lot of topics that we could delve into. But I thought maybe I'd just pick up on something that Annabelle mentioned and something that Adil mentioned, and that is the idea. I mean, Adil, you said there's currently no guidance on who will do the testing for HIV in a person diagnosed with TB in the private sector. And I suppose, you know, you're also working in a different environment than some of the other people who presented, where there is such a low prevalence of HIV. So it might be more difficult to get that moving. If you, like, given your expertise, if you could instruct the government or whomever on how to develop that guidance, what would you want to see occur here?
You know, as I mentioned, that unfortunately in Pakistan, the TB and HIV, these are basically dependent upon, the programs are dependent upon the donor fundings. So in the past, the collaboration between TB and HIV is like, these are the vertical programs of the Global Fund, with very little coordination and very little TB HIV screening. But now, from year 2021, this is very much on the agenda. And we are, you know, in the process of developing those guidelines. As I mentioned, the guidelines were not very much available, but we are in the process of developing those guidelines. And we hope that in a matter of a few months, we will develop those guidelines, which definitely will let us know that how to, you know, screen a patient who is diagnosed with tuberculosis in private sector. There are different discussions going on. Like, for example, when we send the patient to the TB laboratory to undergo sputum microscopy, at that time, you know, the lab technician there, we can just simply train him how to take the consent and how to do the testing, because it's a simple dipstick test, and then how to maintain the records. These are already trained people, so that's another possibility. We're also looking that in the GP clinic, there are mostly paramedics, and we need to train them, and you know, they can just do the testing and take the consent and maintain the confidentiality. So that's another approach. So these are the approaches we are looking after. And also, you know, as we organize chest camps in the far-flung areas for tuberculosis, we have vans that are equipped with digital X-rays, and we can utilize those for HIV testing. So these are the areas that we are looking for, and we are in the process of developing those guidelines. And as I mentioned, that now this is a part of our targets as well for the whole country. So hopefully in the coming years, we'll see progress on this. Thank you.
Great, thank you so much. And now this was also brought up by both our WHO commentators, and I think it's some of our panelists have experience with using these home testing kits for HIV. I wonder if, Nyawira, if you could talk about some of the experience you've had in Kenya with using these test kits, and if this might be a way when someone tests positive for TB, if this might be an easy way to do some sort of HIV screening in a confidential manner.
Thanks, Jody. Thanks for that question. So definitely, self-testing has been rolled out in Kenya, and it is within the national guidelines in terms of one of the modes that are acceptable. And obviously, for purposes, healthcare workers are never enough to do the training. And the people who go to the private sector facilities, even for the TB diagnosis, have obviously gone there because of their preference, but many times because they just view the private sector as more private. You can talk to your healthcare practitioner one-on-one, etc. So the self-testing kits were interestingly rolled out within the private sector even before they were rolled out in the public sector through a pharmacy-based model. And this was good because even if the private practitioner was not able to give the HIV test for whatever reason at the clinic, then you can always refer someone to the pharmacy where they're able to purchase it. I think one of the challenges we've seen is that the cost was a barrier initially, obviously, because it was a new product. We don't have enough I guess, buying power, because it's not, how it is with new medical and diagnostics, it always comes in at a bit of a higher price. So that was a deterrent. However, we did see an increment in the men who would agree to get tested in this way. And so it worked for TB cases that were male. We saw that older males who could afford to go and buy the test would be able to do that. And that was interesting. I think the other thing I just wanted to mention is that for us, at the end of the day, I think while the self-testing, is still going to pick up from the private sector, interestingly enough, all healthcare providers have in-service training on HIV testing using a rapid kit. So this is part of your training in medical school. This is part of your training post-medical school. So it's actually something that they also do at the office. So really, I think for us, self-testings are definitely one of the things. Then the national program is actually pushing for self-testing for contacts, household contacts, as one of the things that, because there's less stigma. I have TB, we have to find out if we're all okay, and can we do that? And especially because a lot of our children also get TB from household contacts. We know that from the data. So definitely one of the models that we're using and pushing towards contact tracing specifically. For the individuals who've come in with a HIV, with a TB diagnosis, then usually the testing will just be done by their practitioner, just because it's practical and pragmatic and everybody has been trained to do it. So I hope that's a useful experience to share.
Thank you. I wondered if we could actually turn to Zintle on this one, given your experience as a survivor, but also your experience of being a mystery client to private doctors in Durban, in South Africa, where the prevalence of HIV is sky high. How did you have experiences where the doctor approached HIV in a way that you felt comfortable with? As a TB survivor, hearing some of these different ways of testing, what would make you feel the most comfortable? Do you have some lessons for some of our private providers listening on how to do this well?
Thank you, Jody. As a patient actor, I really didn't feel good about the way that providers tried to test for HIV when I was a patient actor, because a doctor would come and just bring a finger prick and we should just test for HIV, like without explaining why are we doing this, maybe providing information on why are we actually doing a test for HIV while you are presenting with TB symptoms. So maybe her education to people living with HIV or TB on why tests are done would motivate patients to take a test or to screen, creating that safe space where people living with HIV or TB can actually ask questions regarding a test that is going to be done. It might facilitate people living with HIV or TB to actually take a test because they know why, what are the reasons behind taking the test. So it would be maybe very important to create a space where people living with HIV can understand the reasons behind the test and how it would help in a way.
And on a personal level, if you had the choice as a client to take a self HIV test home or get the finger prick and you get a rapid result, what do you think you'd prefer?
I would, but I would still need someone to talk to. Maybe after the results, what would come out after the results? Maybe someone who would say anything related to the test on what the results say. They would maybe make me feel better regardless of what the results are. Yeah, just
so maybe a rapid test in the office as opposed to a take-home test for you. Yes, personally, yes. You'd prefer that. Okay. Yes, okay, interesting. Great. Thanks for that. Moving over to Refilwe, you talked about political leadership as important for engaging the private sector in HIV and TB screening and testing. How did you manage to do this with the Equity TB Reach project? How did you gain access to TB drugs and HIV test kits? Who was that provided by, and how did you kind of get that political will?
Thanks, Jody. I think One of the good things really which came out of the project was the engagement of the district from the onset. The government had already embarked on a program where GPs were providing HIV tests within the GP rooms and also the distribution of ARTs. Now, the same GPs kept asking, if now we have to manage patients comprehensively, what stops you doing the same for TB patients? Or the same client that I have who is co-infected, why should this client now have to go to a different service if you trust me to provide ARTs for this patient? So that acceptance from the district and the support, I think that's what made the difference. And I noticed one of the participants had asked about the cost of the GeneXpect, which it's both ways. It's even for the GPs. Some of them who were keen to even test the clients, it says, can at least government arrange for us to purchase cartridges at the same government negotiated rate? It's not happening. And for many of us in South Africa, if you might not be aware, some of the big medical insurance schemes have not included GeneXpect. So how do we expect this to be a disease of importance that we need to make sure people get access to it if we cannot even provide that service for diagnostics? So it's something that I think we need to continue pushing to have access to the different tests. For patients, even $1 would be a lot. Yeah. But it's good that government provides free GeneXpect testing for all the patients. So still, I think one of the points that I wanted to make is we definitely need to learn from the different programs. But what I found very amazing was when COVID started hitting home. In 1 week, there were agreements with the private sector, not only for hospital admissions, but for free diagnostics, free drugs, free vaccines, and which again brought an issue. Then it's about political will than saying working with the private sector is complex. So let's hope moving forward here, we can learn the same lessons that private sector, it's not also interested in providing services for patients. But the political will still come. There has to be guidance from the highest level to make sure that we manage TB much better than what we're currently doing. Thank you.
Thank you. Thank you very much. Nyawira, I see you have a hand raised. Did you want to respond?
Yeah, thank you. And Refilo, thank you for that. I totally want to agree with you that one of the strategies that has also helped us in Kenya is to ensure that we work with the national program. And the national program being included in the national coordinators, that accountability. In fact, they come and ensure that within the network, within our Goldstar Network, that they carry out support supervision for accountability of the commodities to ensure that the way the samples are collected, works, and at the end of the day that we've networked with the public sector gene experts and ensure that we're getting results back in time, turnaround time, some of those quality patient-centered results that are very, very important. I also want to kind of bring another side to this. HIV and TB are very donor-funded programs. And one of the things that Goldstar tries to do is to ensure that we have different tiers. There's private sector providers whose clients and themselves will not be able to afford the private sector gene expert prices. However, at the end of the day, the donor funding is slowly declining, and it's useful to ensure that you have a sustainable framework that the current arrangement continues to proceed. And so one of the things as Goldstar we've had is to ensure that there's strength in numbers, that when providers come together, you're able to negotiate lower prices and subsidies for those gene expert tests, even within the private sector labs. Remember, the private sector labs are also part of that's the thing, bring everybody on board. They're also part of the providers. But if you can assure them of, volumes of tests, and then they're able to then have lower prices for the gene experts, because that's another thing. And they're also able to ensure that they're able to have, for the different tests, whether it's even creatinine tests or other tests that have to take place for comorbid patients who might need some of those going forward, whether it's viral load tests. So I think that also is a kind of model that perhaps can be explored, and we have a hybrid that ensures that all the vulnerable populations are also taken care of. But we're also trying to ensure that there's once the donor funding dwindles, or in the setting of COVID, you don't have a complete collapse of the health system strengthening that you worked hard to put together. So I think that for me was my kind of other side of the coin in terms of how to approach this.
Yeah, very important points. Thanks for that. Just speaking in terms of testing, Adil, I heard you mention microscopy. Is Gene Expert a common, is it a first-line test in Pakistan?
Well, we have a huge network of Gene Expert machines. Almost 450 machines are deployed in the country. They are mostly in the public sector hospitals, tertiary care hospitals, all of them have. Then the district level hospitals, all of them have the Gene Expert facilities. Tehsil level hospitals have them. And also in few large hospitals in private sector, they also have Gene Expert machines that are being run by the program, like the Mexico. So the problem was the transport of specimen transportation for Gene Expert. For that, we have developed a rider model where the community volunteers are engaged, and through a mobile application, they are notified that in certain facility there is a sputum sample that they need to take to expert facility. So the riders, they accept that ride, and they take the sample and go to the expert facility and drop the sample, and then the result will be generated through the same system. So we do not have that much problem of Gene Expert in the country. But it's not the you can say that the first line investigation in our system. Still, we have sputum clear microscopy as the first line test. But now, gradually moving into the next year, all of the presumptive cases that report to that facility with Gene Expert available, they will directly be tested on the expert. And those facilities who do not have expert facility with them, they go for the sputum microscopy, and then all the diagnosed patient, TB patient, whether clinically diagnosed or back positive, they should be tested on expert to rule out the sample resistance. So we have a very good network of Gene Expert available in the country.
Okay, excellent. I'm conscious of time. Our time is now up. If our panelists are available for a few minutes longer, we're happy to stay on the line to just wrap up a little bit. I actually wanted to hear from Cheryl in terms of testing. What does the WHO recommend in terms of TB tests for people with HIV? Is there a different guideline in how tests happen when someone has HIV?
I think I might actually direct that to Annabelle, because she leads on the TB side and I'm more on
the
side, but over to you, Annabelle.
It's complicated. No. So yeah, since 2011, WHO has recommended the WHO 4 symptom screen, is what it's called, which is basically cough, night sweats, weight loss, and a fever. And that was developed to rule out active TB prior to providing TB preventive treatment, which is something that we really haven't touched on earlier on, but not much, which is obviously a key component of the sort of the interventions for addressing HIV-associated TB. Now, this year, new guidelines have come out for TB screening, because the symptom screen, which is has been relatively good in picking up TB. It's better amongst people who are not on ART, and that was what the evidence is based mainly on. And it's been clear from different studies that have come up that there are people who are being missed when they're screened with a symptom screen. Maybe this is due to issues of quality, because some people may not want to admit they're losing weight, and different issues. And maybe the person who's given the test, the screen hasn't really sort of directed enough. And so we've got a couple more, I suppose, screening tests that have been added to the armory of screening test ammunition, if you like. One being C-reactive protein, using a cutoff of more than 8. And that is, in fact, what you can do is use the symptom screen followed by CRP. And it has generally the same sensitivity as the symptom screen. For people not on ART. So people initiating HIV care, for instance, a really good way of starting it for them. And it's got a much higher specificity. So it means that there are many more people who can go start TB preventive treatment with confidence, knowing that they haven't got, they're not false negatives. And on the other side, there are many less false positives, or fewer false positives, which means you're not wasting resources on sending people for further diagnostic workup or taking, but expert cartridges and that sort of thing. So those are the and there's chest X-ray. We've known for a while that the symptom screen is not too, has quite a low sensitivity. It's about 50%, 53% sensitivity for people on ART. So it's worth doing an extra special, and some countries are doing this already, to be honest, chest X-ray once a year, just as a sort of regular, as part of their usual checks. So that could be something where I would see somebody, a GP in South Africa, who is a private provider, providing support for people with HIV-associated or HIV. They would then use the X-ray services that are available, and hopefully a contract could be made with the public, the NTP program, to ensure that that's for free and the client doesn't have to pay. And then there is also, we also recommend MWRD, which is molecular WHO approved diagnostics, which is like expert basically, for inpatients in very high burden settings, which is just, as a diagnostic test straight away, regardless of symptoms, because in those sort of situations that people are so ill, really, there's no need for sort of symptom screening, just go forward with the diagnostic workups. So that's, those are the sort of tests that are available now. And I think, there are opportunities within the private provider world in terms of, if, certainly quality of symptom screen, I said, is not so good always. And there may be opportunities to create contracts, which some countries are doing, between private providers and the public providers. So I hope that answers the question.
Okay, thank you very much. I'm just to make sure that I've covered off the questions from the audience. Somebody wondered if you could share your experience about providing HIV testing and counseling and ensuring confidentiality around patients. And there was also a question here around stigma. So just briefly addressing some of those issues and your experience in Kenya.
Thank you very much. So HIV testing and counseling has been a recommendation previously with regards to provision of HIV testing and counseling. But there are discussions around what that does in terms of, from a stigma perspective. Many times if I'm going to test you for pneumonia or I'm going to test you for meningitis out of the HIV space, it's really, these are your symptoms, we need to get this done, let's see how it's going. So I think those are the discussions at the national framework where conversations have been, is this increasing the stigma around the elongated conversations around counseling? What are you doing? So the thought process now here is about providing HIV literacy as you give the test. And that is what, that is a conversation that has been going on. And I want to just frame this in the context of private sector providers. They are thinking about how many patients they have. They don't have a lot of time. Many times they're more stretched. And there aren't even cadres. There isn't this person employed to do HIV testing and counseling. It's usually the person at the lab who's going to draw the blood, or sometimes it's a private provider at his table. So what we emphasize from a quality perspective is, have you provided the literacy of, if this test turns out to be positive, that you've had the conversation specific, we have touch points, you have conversations about you is equals to you. You need to get to treatment, because then, it ensures that you protect everyone around you. And then the conversation around it's early, it's best to start treatment early. These are what the studies have shown, that you have, it's a better chance, and especially if we have TB, HIV co-infection. So I just want to just change that a little bit from that. Of course, consent is very important. The conversations about consent and ensuring that the frameworks in place for confidentiality of the results. We have a HIV tribunal specifically to deal with issues around people disseminating another person's results without them knowing, whether it's in the workplace or whatever other setting. So I think when we have the legal framework, and then the focus is on HIV literacy rather than counseling per se. But I just want to touch on the fact that in our country, we also have a huge push towards assisted partner notification. And I think that's the part now where a lot of counseling happens, because we have to screen for many things, including SGBV and so on and so forth, especially in our context where we have a higher pandemic for HIV. So I hope that answers that question. The second question was around stigma. I kind of, cross-answered that, but we do see that a lot of the ways we've managed to deal with stigma is, again, in the context of ensuring that the space where the HIV testing is done is very private. Again, the private practitioner office way is usually helpful. This is a person who has diagnosed a TB condition, probably, in order to build some rapport around that. We've ensured that in places or in facilities that have a laboratory for specific tests, blood draws, you ensure that there's a space. You need that space anyway for phlebotomy, so you might as well be able to ensure that you have that level. But individual self-stigma, that is something that has been driven from a community messaging perspective. We've had a lot of messaging, especially in the context of COVID, where a lot of people would not maybe want to go into hospital because, is it COVID, is it TB, and in a high pandemic kind of situation. And so just messaging about this is good for you, you're infecting your family, the treatment is free. And even for the private providers, by the way, the commodities are provided free of charge, as a motivation to the private providers to take up this public health issue that does not necessarily have a monetary aspect to it, but as part of your contribution as a healthcare provider. So a lot of messaging, both from the social perspective in social spaces, social media, and as well as from community. And that usually is focusing more on self-stigma more than anything else, because that's what makes people maybe have this cough and not even come to the hospital, especially if they're symptomatic, or be able to go back home with the self-test kits and have their families tested. Thank you.
Thank you so much. I see a couple of hands raised, and I think Rafile will be also able to give a lot of experience, but I'm going to hand it first to Cheryl, just because we haven't heard from her yet. And I suppose you have a lot to say on this subject. Cheryl, please go ahead.
No, just thank you so much for this. And I just wanted to just echo, I think, those same comments, because I think sometimes with our thinking about HIV testing and counseling, we're thinking, back in the 1980s, 1990s, and we at WHO actually recommend brief pre-test information or brief, education and information. The kind of communication around HIV testing and counseling has really evolved, and there may have been programs early on that when there was no treatment or treatment was not, widely available, and we still had pre-ART, that there was a bigger focus around counseling, and that was about, dealing with your status if you were not able to access treatment. And I think that that is an important shift that sometimes I think may not be disseminated everywhere. And we will go to different countries and to different contexts and see some of those old messages. And so I think it's really important that the private sector and private providers are educated around U=U messages, around what it means to be living with HIV today, and really just providing the demand creation. And we see a lot of changes in the way demand creation and testing conversations happen. We saw in our guidance, we actually recommend videos. Videos had a 10-fold increase in the uptake of testing. And so this is a really easy tool for private sectors or for pharmacies, where you could have a video on display sharing information around HIV testing. It is something, even if you're short-staffed, you can have that information being playing in lots of different contexts. We have WhatsApp videos that community providers and others are definitely disseminating. And so the virtual space, I think, is really evolved, and that's something we could really, I think, leverage more so. And that's the same, I think, with prompting people around HIV testing, especially as we talk about TB. We're going to probably be testing a lot of folks who are sexually active for HIV at least once a year. So this is not a one-time thing. So we do have to make sure we have a system that's set up that offers a lot of different options. Self-testing is one option, but I think the comments shared, absolutely. If we can have task sharing and pharmacists doing rapid testing, providing those results the same day, that's really what we want to see from the WHO, is that people are getting tested and then getting their results, being able to be linked to treatment, or even if they're HIV negative, maybe these are folks that are eligible for things like PrEP or PEP, and we're missing those opportunities. I think on the cost that was kind of brought up as well from the private sector, absolutely cost can be a barrier, not just for self-tests, but just even the service delivery for rapid tests. And we were so encouraged by some country programs like in South Africa, where they introduced, HIV testing and self-testing within their state-funded family planning structure. So they were able to then dispense testing for free or for a small dispensing fee of like $1. And so I think there's some really interesting private sector opportunities that we could do more for to really increase that coverage. And I think this opportunity with contact tracing that was also mentioned is in HIV, we're doing a lot of partner notification, index testing, social network testing, where we're following up with at-risk clients. This is an area where TB and HIV could really do more together. It's low-hanging fruit in our mind when we're dealing with clients that have a lot of risk. And if we're promoting one service on HIV or TB, this should be joined up. I think it's definitely an opportunity, and whether that's providing a rapid test on site to somebody, or if that's providing a self-test because you don't have somebody who can run that. I think one of the perks I see for a context like Pakistan, and I know they have a national policy on self-testing, but I know it's not yet available, is if you don't have a decentralized system where lay providers or not as many individuals can perform HIV testing, self-testing does enable you to leapfrog over some of those barriers. And so I think that is an important thing for private sector providers to think about, is depending on their context, pharmacy councils, local government, there may be some opportunities to think about what's the right option. And I think that's really an important thing to think about. But then I think one of the points that I also wanted just to raise is, while we've talked about a lot of the community, or sorry, the government relationships with private sector providers, the community relationships are really important with the private sector providers as well. And especially when it comes to the demand creation or the follow-up, these services really have to be designed with community engagement, even if I think that's something sometimes we emphasize in a public program, but doesn't necessarily come out in that private sector program all the time. And I think there's lots of opportunities for that engagement to be moving forward. And really, when it comes to HIV testing, I think we see a lot of opportunity to leverage what's already happening, but we could definitely be doing more together on TB and HIV testing and screening.
Thank you. So a lot, I mean, there are a lot of topics coming up here, and we are really drawing to an end here. But I think this is just showing the fact that there's a lot of interest, and there's a lot to get right and to learn from one another on HIV and TB screening happening together, working with the private sector, working with communities, working with government. I mean, we talk about the private sector as one thing, but it is also so many things, including formal and informal and different types of private providers. Rafilwe, did you have anything to add there? Or should we?
No, I think
or was
just
your topic
a
covered?
quick one, just from what also Annabelle said, the opportunities. One test that really saves lives is urinary lab. Whether it's in the public sector or in the private sector, but it's the dissemination, and also for people to know it's a good test, and it does save lives, because the people we pick up with TB are really at the end, but TB treatment can be initiated. And also the access to chest x-rays, we're seeing it more here, also under the different programs, that access to chest x-ray for the private sector and the public sector, we are able to pick up TB early. The results of our different prevalence surveys have shown that we need to improve access to chest x-rays. Thank you.
Thank you. Thanks so much, Rafilwe. Annabelle, I see your hand raised. Do you have a quick one? Just before we close
just a
out?
brief one, just to say that I bet absolutely LF-LAM is great, but it's not a screening test. In this session, we're talking about screening tests, but for diagnosis, yeah, it's great. And I think, yeah, I agree. I think we need to roll out digital X-ray as soon as possible and really get that through. Thanks a lot.
Excellent. Thank you so much. We're final word. Oh my gosh, guys.
No final word, really. I just wanted to bring out the context of private sector in the context of workplaces. I know this was a game changer for us, ensuring that, workplaces where people spend almost 8 hours a day, and so are places where people can continue to have the conversation around HIV testing and TB testing, and conversations. One, for literacy, for people to understand what the relationship of how the two are related, which obviously they take back into the community, and also strengthening the workplace clinics where people kind of also start feeling familiar in terms of the provider who is available with them, and especially in pandemics, where in countries where you have both TB and HIV, having a very high prevalence. So for us, that's one of the game changers when we went in the workplaces, and I wanted to make sure that we share that for anybody else who might be, wondering how to expand the private sector HIV-TB screening. So thank you very much for having me.
Thank you. And everybody's still on. So Adil, please, if you have one last thing to add, please go ahead.
Yeah, just to add that, sharing our experience with the X-rays, not all the private healthcare providers, they are able to read that chest X-rays, and they are not able to make diagnosis on the basis of that. So we are using a software, but Delft Imaging, this CAT for TB software, it's really very helpful. So just want to make that point. Thank you.
Excellent, very good. And I don't know to what degree that's available in all countries as yet. But Petra, I hope you're taking a lot of notes, because it sounds like there are a lot of great topics that TBPPM can pick up for further discussion. And I know there's a webinar coming up on preventive treatment for TB, which is a topic we didn't even start today. So I'm going to hand it off to Petra just to say thanks to all our speakers. But thank you for giving me the opportunity to moderate such an interesting and lively discussion.
Thank you. You did a wonderful job, Jody, as a moderator, and I really want to extend my big thanks to fantastic presentations, all three of you, and a great panel discussion. Thanks to Cheryl and Annabelle for joining the panel discussion and making this lively topic. I'm not even going to try and summarize. I'm just going to flag 4 topics that I know we have to do webinars on. And one is workplace, TB and HIV integrated services, and really talking about how to use workplaces in a better way. And the other one is related to diagnostic testing and the whole discussion around cost costs of testing and what types of testing, when and what, and in which moments of the care cascade. The issue of stigma related to human rights related issues that came up a few times, but we haven't really had a chance to dive into more deeply. And Zinc Twane, thank you so much for sharing your experiences, because that really, I think, is a topic where we can have a full webinar on. And then communication and how to better raise awareness and make connections with the community. And maybe the last one was the domestic funding and the sustainability of programs as a key point. And that's relevant for both HIV and TB, but definitely a topic when we think about engaging the private sector in a larger way. So thank you to everyone for staying on the line. Thank you for the wealthy debate here on our panel. Really appreciate it. As Jody said, next week we are talking about TB prevention, and that's so closely related to this topic. So it will be a nice segue into that. And I want to wish everyone, as you know, it will be available on YouTube. We will post a report and everything will be available. And I know we have a large audience that has signed up. And in busy December, I know they will be watching the recording. So anyone who's watching the recording, thank you. I'm going to launch a quick poll just for those of you who are here who want to give us some feedback, and feel free to write to us anytime. Thanks to everyone on this panel, anyone listening in, wishing you a wonderful rest of the day or evening. And with that, we're going to close, and I'm looking forward to continuing discussion. I really see this as the #1 in a series of, so I really appreciate your time and your thoughts to kick this important topic off. So thank you so much.
Thank you very much. Bye.
Thank you. Bye.
Thanks.
Thanks. Bye.
Thank you. Thank you.